better. It's magical for you as a therapist. It's very rewarding for me as a therapist to be able to see people feel so much better, bond better with their babies. And so that's kind of the little thread of sunshine to have, I think, whenever we're talking about perinatal anxiety and OCD, because it is such a devastating disorder in a lot of ways, and people are so very, very uncomfortable, but we can get people feeling better. And so the learning objectives for today are to understand how to screen for and diagnose perinatal anxiety and perinatal OCD, identify the unique diagnostic factors and clinical presentation of anxiety and OCD symptoms during the perinatal period, and describe some appropriate treatment options for perinatal anxiety and perinatal OCD patients. So we will start off with the basics, beginning with, these are just, again, like, honestly, none of these is one specific quote from a patient, because I've heard something along these lines from many patients who are coming in to see me with some form of perinatal anxiety. And so the first thing that I see coming up, I just have had this bad image. I can't shake that I'm going to overdose. I can see myself taking the pills and my daughter finding me. Another patient may be sharing something like, I feel like I'm always waiting for the other shoe to drop. I hear that a lot on the hospital side of things, when I'm dealing with somebody who's had high risk pregnancy or they've got an infant in the NICU, just kind of, I can't even enjoy the good periods because I'm waiting for something bad to happen. I've heard I can't stop my thoughts. My thoughts are always racing. They're out of my control. My brain feels like hell is something else I've heard very frequently. I can't do anything right. I feel so scared. I just want to be a good mom. And then finally, I can't walk into the hospital for my daughter's appointments without feeling like I'm going to die. A lot of times, again, like especially for folks who've gone through a high risk pregnancy or something similarly traumatic, there's this feeling of I can't even get on the road that we took to come to the hospital to have my baby. The moment that I'm on that road, a panic attack is starting, or I can't even reach out on my Connect because I'm so used to opening up that app and just getting updated labs or like messages with bad news. And so starting off with our prevalence, so we now think, I mean, depending on what research you're reading, we find that perinatal anxiety is incredibly common, even though it's not as talked about as perinatal depression. 20% of peripartum women are going to meet criteria for at least one anxiety disorder, and then close to 6% are meeting criteria for two or more anxiety disorders. And we think in some circles, this might actually be more common than perinatal depression, again, depending on the research that you're looking at. We also see that the prevalence will increase within low and middle income countries. And for folks who are going through medically complex or high risk pregnancies, we're going to see perinatal anxiety higher with those populations as well. And over the course from first trimester all the way to the postnatal period, we see that the prevalence of anxiety starts to increase with each trimester, starting at about 18%, all the way up to 25% for the third trimester. A lot of the fears there are around childbirth, potential fetal anomalies, like concerns about like, am I going to be okay? Is the baby going to be okay? And then there's a slight drop back to that baseline 18% postnatally up to, again, 12 months postpartum. We frequently see anxiety comorbid with depression, but again, depression has a lot of the spotlight on it right now. We've got universal screening. We're talking a lot about it, which is really, really great. But unfortunately, that means that we miss a lot of anxiety symptoms, and we're not adequately treating those anxiety symptoms if we're not seeing them. And then we can see with anxiety that it's associated with poorer maternal and neonatal outcomes, and I'll talk a little bit more in a few slides from now. So perinatal anxiety actually in and of itself is not a diagnosable condition. If you open up the DSM, there is nothing there that says perinatal anxiety. I think you can give them the ICD-10. There's definitely something there that we can code, but this umbrella category actually encompasses a really heterogeneous group of disorders. So you can see under this umbrella, we've got like PTSD also falling under the same category as OCD or panic disorder, agoraphobia, and all of those are falling under the umbrella of perinatal anxiety. Within the sphere of perinatal anxiety, GAD or generalized anxiety disorder is the most commonly that's going to be seen. And it's then followed by social anxiety, specific phobia, and then PTSD, with all the rest of them kind of falling behind. GAD is incredibly common. We see it obviously outside of pregnancy as well, but whenever it comes to pregnancy, the part that can, again, add that perinatal language is that a lot of the fears are going to be around motherhood, baby, parenthood, family dynamics. And so considering how heterogeneous this category is, oops, just scrolled a little bit too far, there we go. I wanted to have like this little table up here of like, again, each of those disorders kind of with some of our key factors. Obviously, go to the DSM for the full diagnostic criteria, but I didn't want to bore everybody with that here. But some of those key indicators for each of these disorders, the impact that we're going to see on functioning when a patient is coming in and talking with us, and then the length of time that we want to see symptoms, which is very interesting to think about in the context of the perinatal period, because that's a discrete time period that like for some patients, we might be seeing somebody who's coming in with anxiety, but only for 1 month. And so maybe they don't meet criteria for GAD, that question of like, what diagnosis are we giving at that point? So the first thing I also want to say, and this is coming from the mindset of like culturally, as we talk about mental health, we talk about like, oh, that person's bipolar, right? And like what we're really referencing is that like somebody's got mood swings going up and down. And that same way, I actually have a lot of patients who will come in and they'll talk about panic attacks with me. And when I kind of dive in and ask follow-up questions, turns out they're not actually experiencing a panic attack. What they're experiencing might fall more under the line of an anxiety attack. And the way that I would like treat and intervene on that is going to look a little bit different. So I have kind of our descriptor up here just to keep in mind also that panic attacks can occur across all of these disorders. And that we can see it's a transdiagnostic symptom that can come up. And so panic attacks are going to have this rapid onset of symptoms. Usually one of the key questions that I'm going to ask is, how long did your panic attack last? And if I have somebody who tells me it lasted all day, right, I know right there that that probably was not a panic attack, probably an anxiety attack, and we're going to strategize and treat that a little bit differently. Usually we're going to see it's accompanied by physical sensations like sweating, shaking, chest pain, shortness of breath. We're going to have derealization, possibly depersonalization coming up. So somebody feeling like I'm in a dream or this is a dreamlike world. And then this fear of dying or fear of losing control. And again, we can see that across all of these diagnoses. With GAD, what we're thinking about is somebody's going to come in and they're going to present as a very worried, stressed, anxious person, and they're worried about a lot of different things. Oftentimes, they'll come up with some somatic symptoms as well. So we'll see somebody who maybe has a little gastrointestinal upset, like a little IBS, a little bit of butterflies in the tummy, maybe some headaches going on, something like that, muscle tension. All of those can commonly be seen with GAD. From an impact on functioning, the biggest thing that we're going to see a lot is this is somebody who's spending a lot of time in their head, right? They're doing a lot of ruminating, a lot of worrying. I'll talk about it a lot with my patients, and we talk about like they're stuck in a loop. It feels really hard to get out of that loop and come back into life. And so there's a lot of this happening up here and not a lot of like person to person living. And we expect to see GAD, this anxiety and worry needs to be present pretty consistently almost every single day for a lot of the day for 6 months. And then we've got social anxiety that actually can come up for a lot for parents in the perinatal, like the pregnancy period or the postpartum period. And so usually this is a combination of I'm afraid of social situations and I'm also really, really afraid of how other people are going to perceive me in those social situations. And so I might hear moms coming to me and they're talking about like, again, in general, life feels really good until I go to take my kid to the playground. And then I'm very, very self-conscious. I don't want to go to the playground, even though my kids love it. I love to see my kids being so happy because I'm so self-conscious that somebody's going to see me be nervous and think that I'm a bad mom, think that I don't know what I'm doing. And so we'll see that the impact on functioning here is going to be social avoidance, right? Or extreme, extreme fear, maybe even panic attacks in these social settings. And then we've got a specific phobia, which might be relevant, especially like I've had some folks who have a specific phobia that might develop during the pregnancy period where let's say that there's a concern for possibly some hypertension or preeclampsia or something similar, they might develop a phobia around like getting their blood pressure checked, or they've got to take these medications and they've got a specific phobia around swallowing pills. And
Already?
so a lot of times what we'll see in that situation is that there's avoidance of those either objects or activities that cause a lot of stress and anxiety. And again, we want to see those symptoms be present, not just for like a one-off kind of appointment where somebody feels a little nervous. We want to see that consistency over time. And then PTSD also falls under this umbrella for pregnancy and the postpartum period in particular. We want to be thinking about fear of childbirth, birth trauma. If this is not somebody's first pregnancy, there might be a history of pregnancy loss that can cause PTSD symptoms, or even a prior birth trauma that can be re-triggered with a subsequent pregnancy. What's kind of complicated, and especially if you're somebody who's been in the perinatal sphere, is birth trauma is it's another umbrella category that can be really, really broad. And some things that are perceived by a patient as like, this was birth trauma, this is a traumatic experience, I'm having lots of symptoms as a result of my birth, would not fit under this like criterion A kind of diagnostic category of either actual/threatened death, serious injury, or sexual violence. One of the biggest things that can lead to birth trauma is poor communication from the medical team or misunderstanding or lack of information around the birthing process. And while those things might not meet criterion A trauma category, it might like only be classified as an adjustment disorder. For us in the perinatal world, we want to treat birth trauma with that same level of seriousness. And a lot of times the interventions can still be the same, even if it's not technically meeting that initial criterion A requirement. For here, we're going to see like quite a variety of symptoms and what can happen. But in general, we notice like avoidance is a big functional impact. We'll notice that there's big mood changes, which again can influence avoidance or engagement in valued activities. And then we're going to have intrusion symptoms and those negative changes to mood and thoughts. For PTSD, we want to see those symptoms be present for at least a month. OCD, which again, we're going to spend a lot more time talking about later on in this presentation. Another anxiety disorder, it's got its own category in the DSM. What we're looking at here is we need to see a combination of obsessions and or compulsions. So there is a subset of OCD that's called pure O OCD, where you can have somebody who has just obsessions and no compulsions, but it's very unusual. Oftentimes, more likely what you're going to see with a perinatal in front of you is that they have obsessions and then they have like internalized compulsions that you can't see from the outside world. And that's what you would want to intervene on. So that might look like somebody who prays 70 times a day to make sure that their child doesn't die from SIDS, right? Like we might not be able to see that from the outside world, but that would meet the criteria of a compulsion. Again, we're going to see that this is time consuming. Usually we're looking for those compulsions and obsessions to take at least an hour of the day. And we want to see consistency across minimum of 2 weeks, if not longer. And usually OCD is a very chronic disorder. I think the median number of years it takes for somebody to actually get into treatment is like 9 years. So oftentimes these symptoms will have been present for a very long time. With panic disorder, it's where somebody's experiencing recurrent unexpected panic attacks and they've got a fear of these panic attacks happening, which can lead to avoidance. I'm avoiding potential triggers. I'm avoiding situations where I could feel that way, and that's lasting for a minimum of a month. And the final disorder that we can see coming up, which again, I think relates to some of these earlier disorders when we're thinking differential diagnosis of like, is this social anxiety? Is this a specific phobia? Is agoraphobia, where we have at least 2 different of these places that we're feeling afraid of. So we're afraid of public transportation, we're afraid of open or enclosed spaces, we're afraid of big crowds, big lines, places where we could get stuck, and then leaving the house alone. And again, what I'm seeing as far as an impact on functioning is a lot of times this is going to be avoidance or over-reliance on a companion to get through these things. I can't do stuff by myself. And I expect to see these symptoms for a while. So taking the biopsychosocial approach, these are some risk factors for perinatal anxiety disorder, something that if you're meeting with someone the first time, some things that you might want to ask about that gives you an indicator of what could be coming up. So from the biological side, if we see somebody who has pregnancy or medical complications, so this could look like somebody who's got a high-risk pregnancy complication, but also could be somebody who's had chronic health conditions or just in general has other things happening in their health, that the pregnancy is like a secondary thing that just happened. Obstetric complications and mode of delivery. So we see that someone who's had a C-section, especially if it was emergent, unplanned, unanticipated, that can increase the likelihood that they'll have postpartum anxiety. From a social perspective, folks who are isolated, limited supports, unsupportive partner, if this was
You're good.
a pregnancy that again like doesn't have a lot of community support around it, that can lead to an increase in anxiety. And if there's a family culture, that's usually the language that I kind of use when I talk with patients, is this idea of family culture and like our attachment with our parental figures and adults that were in our lives. If there's a family culture around rigidity, that can also set somebody up to being predisposed to being more anxious during the perinatal period. From a psychological perspective, a history of abuse or domestic violence within the current relationship with like a father or a partner of this baby or with a previous partner can influence increased anxiety at subsequent pregnancies as well. If there were any previous psychiatric diagnoses, especially OCD, especially anxiety, especially prior PTSD, that can elevate the risk. And then if there were previous pregnancy losses, so somebody who's gone through a miscarriage before once, or especially if there's been recurrent pregnancy losses, I am anticipating that there's going to be anxiety in subsequent pregnancies. And also related to this is the fertility journey. So somebody who's had to go through fertility treatments, oftentimes they're at higher risk for anxiety during pregnancy and the postpartum period as well, and just increased rigidity around all of that. If the pregnancy itself was either unplanned or unwanted, we can see an increase in anxiety and then high perceived stress. So it's not just the amount of stress that somebody is over, but how overwhelmed they themselves are feeling. So if they're feeling quite stretched thin, I might see a lot more anxiety in that picture then. And so some additional clinical variables to think about from not just like the interviewing, like again, I'm trying to figure out what diagnosis is sitting in front of me, but from a treatment perspective is some common threads is I'm going to see a lot of avoidance happening. Cognitive rigidity is really, really common with this population where it's like we kind of get stuck on doing something one certain way and it's hard to pivot or be a little bit more flexible. And there's oftentimes a lot of dysfunctional beliefs that can come up. So I'll talk to somebody and, they have it in their head that like I have to eat a certain way because that's the safest thing for me and my baby. And we'll kind of explore like, but what would happen if you deviated even a little bit from this? And there's oftentimes this belief that, oh, for me to deviate even a little bit would hurt my baby, right? And that can be a very dysfunctional belief, can lead to a lot of this anxiety being maintained. And then another thing to keep an eye out for whenever we're interviewing about social supports and family support is that friends and families can, through no fault of their own, they can actually unwittingly collude with the anxiety. They can be a partner to the anxiety itself by supporting avoidance strategies and reducing their loved one's distress. One symptom I talk a lot about, especially with OCD, is something called reassurance seeking, where I feel anxious and I want to ask somebody close to me, like, is the way that I'm thinking about this crazy? Or is this idea that I have, is that going to make sense? So I ask somebody close to me, my anxiety goes down. But with somebody who has perinatal anxiety or even perinatal OCD, that reassurance is only temporary. And oftentimes I become more and more reliant on other people's opinions and ideas. And I feel less comfortable and trusting my own judgment when it comes to decisions. So thinking about maternal and neonatal complications that can come up here. So I've got up here kind of like some general outcomes that we can see for the birthing parent themselves, along with the infant, and then across the entire family system. So for the birthing parent, we hypothesize that with anxiety, we see neuroendocrine changes, and this can have long-acting effects for the birthing parent, even post the postpartum period. We can see that those last for, many, many months and years. We also see that for birthing parents who are pregnant and have anxiety, there's elevated rates of gestational hypertension, preeclampsia. Both of those are blood pressure disorders. Both of those have ramifications on delivery timing, recovery after delivery. And so it's something to think about as well. And then in general, the quality of life is poor. If you're living every single day with like unmanaged, like anywhere from mild to severe anxiety, we're going to see that life just doesn't feel as enjoyable as it could if you didn't have this anxiety. And because avoidance is such a big picture with anxiety, we'll notice that the overall functioning is going to also be impaired because we're not doing all of the things that we would be doing if we didn't feel anxious. I'm going to see greater emotional distress and comorbid mental health disorders. So folks with anxiety are more likely to have depression, or more likely to have another anxiety disorder, or at risk for all of these outcomes. And so I want to be aware of that as well. And then in the postpartum period, also during pregnancy, but especially postpartum, I see reduced responsiveness to their infant, or even inappropriate responsiveness to the infant, or misunderstanding or misreading cues. And that can impact the attachment with the infant themselves. And then for an infant during pregnancy, moving into the postpartum period of post-birth, we can see that there's altered neurodevelopmental outcomes whenever they're part of a pregnancy where parent was anxious. And also socio-emotional and cognitive deficits can be developed in later childhood and adolescence as well. Around the timing of delivery, we can see that there's an increased likelihood there's a preterm delivery or low birth weight for these infants. And then during the pregnancy itself, these infants can sometimes be less likely to grow as we would want them to grow during the entirety of the pregnancy. There's elevated neonatal inflammatory markers that can also be seen at the time of birth, which again, all of these we'd like to avoid if we can treat this anxiety and reduce that distress. Across the family system, for families that have a parent struggling with anxiety, we see there's impaired bonding and attachment just in general. The family is impacted by this anxiety. We see from a medical system perspective that there's a higher utilization of emergency services, requests for unnecessary interventions, and there can be potentially indirect harm, especially if we think about a disorder like OCD. If I have somebody who has contamination OCD, that might mean that I am over washing their hands, or I'm cleaning them with chemicals that are not appropriate for cleaning an infant. I've had patients before with OCD who, are so concerned about like any sort of potential stool whenever they're doing a diaper change that actually it leads to diaper rash because we're over rubbing, right? And again, this parent is not trying to harm their child. This is indirect harm that's coming from the compulsions of the disorder itself. And then finally, having one partner that's got anxiety can increase the likelihood that the other partner might develop depression symptoms or anxiety symptoms themselves. So again, we kind of see this across the whole family system, which means from a treatment perspective, if we can intervene on one person, we could actually have this really positive effect across the entire family unit. Okay, and so what makes it perinatal? So again, like the common things that we want to think about that specifically would come up with our patients is fear of childbirth, processing birth trauma itself, as has happened during a previous pregnancy, maybe before we knew a patient, or happened during this current pregnancy. A lot of fear around health of baby and mom, and that doesn't just go away after baby is born, right? Then there's new things to be scared about for a new parent. The loss of identity. I see this coming up a lot also for parents who intend to be working parents, that loss of identity of I was used to being one thing and this is how I interacted in my workplace and this is how I interacted in my family. How do I now incorporate this new part of my identity of motherhood into my role as, a worker at this place and interacting with friends in this way? In general, this idea of being a good mom comes up all the time. We see it of like, there's now so many books and like ideas of like, do you want to be a tiger mom or a helicopter mom or all of these different things that it's not super clear how to make the right choice of what being a good mom is. And so that can raise a lot of anxiety of how do I make the right choice for me, for my family, and for my baby? And then judgments from others. We also live in a society that I think is pretty quick to be judgmental of moms, especially. We hold them to really, really high standards. There's lots of stuff that moms can do that is the wrong thing. And so walking out in the world, there's a certain level of like reality-based fear of like somebody around me could be judging me for anything that I do in this moment, from like walking into a grocery store with a crying baby to trying to load up a car with the groceries right afterwards. At any point, somebody could be looking at me and making judgments about the kind of parent that I am. Okay, and so I want us to take some time and dive a little bit deeper into what perinatal OCD can look like as well. So the first thing to remember, and this is like, I think one of my favorite statistics to have, is that up to 65% of new parents are going to have an intrusive thought, and that doesn't mean that they have OCD. And this happens to both dads and moms or partners or whoever's part of that dyad. This is incredibly common. We know that intrusive thoughts are going to happen. Now, what happens with the OCD picture is, especially for somebody who's got like maybe that family culture around rigidity, or maybe there's like kind of rules in our head around what thoughts are safe or not safe, we can see that those intrusive thoughts can take on a life of their own. They become like really sticky, is the language that we use with OCD, of having sticky thoughts. And it's folks that have those sticky thoughts that we can't tolerate, or we have to do something to make the distress go away. That's where we can start to develop OCD symptoms, and it becomes much more severe and something that should be treated and addressed. We see that 8% of pregnant and 17% of postpartum birthing parents can develop new onset OCD symptoms. So this is somebody who, again, might never have had a history of this before, though oftentimes I found, like just in my clinical practice, that if we dive a little bit deeper in childhood or adolescence, I notice something like the way that I use it when I'm talking with patients, which does not have to be the way you talk about it, is like them being a little bit jinxy. So like I'll talk to somebody and maybe we're like, at this point, we're quite a few sessions in, and all of a sudden they'll kind of remember like, well, wait a second, when I was on my high school sports team, I had this like little routine that I would do to make sure that our team won. Or I would always do this thing before a really big test. And so we can see that there sometimes is this link of like functioning compulsions that are happening that just get exacerbated in the perinatal period. And then for folks who already have an OCD diagnosis, we can see this is a really vast range. We can see anywhere from 8 to 70% of those parents can experiencing a worsening of their symptoms during the perinatal period specifically. And we think that there's a bunch of different reasons why this could be happening. Could be hormonal changes, so the research is a little bit split on that. It could be the sleep deprivation, the transition from like not really being responsible for much other than me to like now I have this whole infant that relies on me for everything that they need. But there's a number of factors that we think that make it that somebody who's had OCD before, it can get worse again. And then for the general population of OCD patients, 69% of those patients will have a comorbid psychiatric disorder. And what feels really relevant as we're thinking about the perinatal population, again, outside of that, the most common disorders that we're going to see come with OCD is going to be depression. It's going to be panic disorder. And then we also see substance use disorders actually are very, very present with OCD as well. And again, the hypothesis there is that the anxiety, the distress, it's so uncomfortable and intolerable that substances can be used to try to make those symptoms feel more tolerable for somebody. So it's something that we want to think about with the perinatal population as well. We want to be looking out for depression. We want to be looking out for panic symptoms. And we also want to be just like checking in about their reliance on THC again, or cigarette smoking or alcohol, in addition to other substances as well. Okay, and so related to OCD, something that we want to be thinking about always is we'll talk about this idea of like, do they have good insight? Another phrase that gets used a lot is this ego dystonic or ego syntonic? The typical OCD patient that we have is usually very motivated to come in for treatment because they feel terrible. They're like, there's something wrong with my thoughts. I know it's not right. There's something irrational happening. And that's that ego dystonic idea is like, I'm having thoughts that feel really misaligned with the kind of person that I am. And this feels wrong and scary. And so I'm coming to somebody asking for help about it. However, there is a small proportion of OCD patients that can have poor insight or like delusional beliefs that are very fixed and are hard to intervene on. Those patients, unfortunately, don't do as well as in treatment, and they might need a combination of psychotherapy plus med management to manage the intensity of those symptoms. You can also assess insight during your clinical interviews just by kind of like gently questioning, like, so what would happen, do you think, if you didn't engage in this compulsion? You know, there's a contamination fear and somebody has to wash their hands 10 times before they can leave the bathroom. You know, that gentle question of what would you do if you didn't wash your hands 10 times? What do you think would actually happen can also get you insight, but there is a questionnaire, the Brown Assessment of Belief Scale, that would assess for delusional beliefs and can be helpful if you want something a little more formalized. The reason why assessing insight is incredibly important is one of the disorders during the perinatal period that perinatal OCD can be confused for is postpartum psychosis. And part of that is because of the things that become sticky in the perinatal period can have some overlap when somebody's talking about it with a provider that sound like, could this be a delusion? Could this be a visual hallucination? So when I'm thinking about OCD, some of the things that I'm thinking about if I'm trying to figure out, could this be a presentation of postpartum psychosis, or could this be an example of OCD, is I want to pay attention to the insight. And I also want to think about symptom consistency across time. So with perinatal OCD, I'm expecting that symptom consistency is pretty persistent and constant with time. I'm not going to see a lot of big waxing and waning. I'm going to see somebody who these thoughts are present much of the time or a good chunk of the time every single day for like weeks to months on end. Again, like I'm usually expecting to see somebody who's got good insight into like this feels irrational or this doesn't feel like this is reality based. I'm scared of these thoughts or these thoughts make me uncomfortable. But even when people have poor insight to that, again, I'm going to expect to see that real level of consistency there that could help me to feel like, okay, this feels more like OCD to me. And another thing to think about as well, and this is in line with like, again, like if I'm comparing obsessions versus delusions, obsessions are going to usually come with some sort of a compulsion that is aimed at reducing the distress raised by the obsession itself. When I'm thinking about treatment questions, and again, this is for like comparing OCD versus postpartum psychosis, if I think somebody's got OCD, my goal is to keep them out of a hospital. A hospital stay is not going to help with OCD. It actually can oftentimes make things worse because I am helping to collude with the avoidance by taking them out of their environment. I'm almost reinforcing this idea that they're not safe to be around, right? So I want them to stay as close to the normal environment as possible. And our goal is going to be increasing functioning and reducing the symptom intensity. So that means that like that might be outpatient level of care, maybe therapy only, maybe therapy and management. It could include an IOP or a PHP program, but I want to keep them as much as I can within their social support network, within their community. That way we learn how to live with OCD without having to pluck you out of your real life. There is an elevated risk of harm to self just because of OCD in general. Like there is an association between suicide risk and OCD because those symptoms are so distressing. The thoughts can be so upsetting. And so it's something that we want to keep an eye out for, just making sure that you're doing regular suicide risk assessments with somebody and talking about it. That way, this person knows that they can talk about it with you. But it is also, because OCD is like this, it's very possible for somebody to have an obsession about being suicidal. And so we just would want to keep an eye out for that. Some additional language here about like kind of helping to differentiate between an obsession and a delusion, right? Is that I would, again, I'm expecting that for most people with OCD, these thoughts feel really distressing versus somebody who's having a delusion. This feels like a fixed false belief. I believe this. I don't have insight that this could not be true. I truly believe that there's a possibility that my child has been replaced by a changeling child. This is not my baby. And the way I get my baby back is by, giving up my baby or hurting my baby somehow. So that brings us to postpartum psychosis, which is a medical emergency. And when I'm differentiating between those two, right, like with postpartum psychosis, that is going to require immediate intervention and likely an inpatient stay to stabilize somebody before we get them back out into their community where they're going to have more of a long-term treatment progression. Here, I can expect that a lot of times for many patients undergoing postpartum psychosis, we can see their symptoms wax and wane. So there are some periods where they kind of like seem like they've got it together. It seems like they're thinking like normal. And then they have a period again of like real decompensation, saying things that don't make sense. They're not looking really well. And then they kind of get better again. So if I'm seeing that kind of a presentation, my mind is jumping towards, could this be postpartum psychosis? I also am going to see additional psychotic symptoms, like in addition to delusions that could kind of sound like an obsession, I might see hallucinations. I'm more likely to see disorganized thinking. There could be some mood symptoms, maybe some mania or severe depression coming with that. And then also behavioral changes. I might also want to just take a look at like how that person is presenting in the office to me, because it's much more likely that I'm going to see like a disheveled appearance with somebody who's going through a psychotic episode than I am with somebody who's going through an OCD episode. And with postpartum psychosis, what we're always thinking about is there's a real elevated risk of harm to self and harm to the infant with this situation because of the delusions and the illness itself. And so what does OCD look like in the perinatal period? If I have somebody who has symptoms that start during the pregnancy, what I most often will see is washing or cleaning compulsions. I'll see that somebody has a real fear of accidental exposure to poison or chemicals, and so they might be overly cautious with the foods that they're ingesting, their cleaning routines around the house. And so that's where I'd want to take a look at for compulsions. It's not to say there couldn't be other obsessions that come up, but this is really common during the pregnancy period. And then in the postpartum period, I'm actually going to see this shift into more avoidance or checking compulsions, where somebody is either monitoring their thoughts. Like, for example, like I've had patients with OCD before who have had really intrusive and distressing obsessions about killing themselves, where they will tell me that they've had like a vision of themselves hanging from their ceiling. Like they walk into the living room and they see it. And again, this is why it's so key to really differentiate between, is this like a hallucination, like postpartum psychosis, or is this like a really strong obsession that has come with this visual imagery, and what happens after you have this kind of thought? There's oftentimes like concerns about inappropriate thoughts regarding the baby. Am I somebody who's going to hurt my baby sexually? Am I somebody who's going to accidentally injure my baby? And then what I see a lot of times, especially parents who've had to go through a NICU stay or have had an infant who has some sort of an anomaly or a medical concern, is something that we can see at night is like, I can't fall asleep. I'm terribly sleep deprived, but I have to keep my eyes open to make sure that my baby is breathing, and I can't not check that my baby is breathing. So moving into some screeners that you might want to use if you're considering assessing for anxiety within your clinic setting or wherever you're located. So the first few that I'll talk about are just focused on anxiety broadly, starting with the G87. This is one that I use quite frequently. It's very easy to administer. It goes along with the PHQ-9. The interpretation actually is quite similar with the PHQ-9. So this is one that if your clinic is already using it, I think throwing this in there and adding it on is a really quick and easy way to do that, and like have like a more uniform presentation for patients, but also for other providers as well. Here we're looking for a cutoff score of 10 or higher. And if I see that, like I'm starting to think about like largely a GAD presentation, because that's what these symptoms are associated with that they're asking about. There's also a shorter version, again, depending on the setting that you're in, where you could use a GAD-2, which is just like a very quick and dirty, okay, do we have any anxiety symptoms going on? And I'd have to follow that up with more questions as well. The one caveat with this one is obviously it's not perinatal specific, so I'm probably going to have to ask more questions if I'm treating somebody who I think might be at elevated risk for anxiety based on the results of the screener to figure out what exactly is happening here. There's also this hospital anxiety and depression scale, or the HADS, which is 14 items. It's a self-report scale. It's also not perinatal specific. There's two subscales. There's one for depression and there's one for anxiety. And for the anxiety subscale, the cutoff is 8 or higher. So each of them, same number of items, same cutoff scale that I'd want to be thinking about. This is another one that's like really easy to implement. It's good across like a variety of settings, hospital, community, psychiatric clinic, wherever you're kind of based, and is also a little bit more inclusive anxiety and symptoms outside of just the generalized anxiety symptoms. We have some symptoms that address panic and other anxiety things that we can see coming up with this population. This screener is familiar, I would hope, to most people if you've done perinatal work before. It's the Edinburgh Postnatal Depression Scale, or the EPDS. It's like the gold standard that we use to assess depression. There's actually an anxiety subscale. It's the 3 items that I have on here, item 3, 4, and 5, that specifically ask about anxiety symptoms. And so the way that when they've done research on looking at the EPDS, for somebody who has no depression or anxiety, we're going to expect that their scores are the lowest, looking at the overall total score, right? And then if they have anxiety symptoms alone, that's that next category before we see depression alone or folks who have anxiety and depression. And that's kind of the range of how total scores can look. So what's key to note there is it's very possible for somebody not to meet our EPDS cutoff score, which depending on the clinic that you're in, like I typically use a pretty conservative, like anything that's a 10 or higher. I could have somebody who's not elevating that overall score, but if I look specifically at these 3 items, they might meet my cutoff there. They might have these anxiety symptoms, but none of the depression ones. And so the cutoff score here is a 6 or higher. There's also, if you're interested in looking at this a little bit more, want to do some partner work, there is a cutoff score of 4 if you're giving this to partners as well. So this can be used for both the birthing parent and their support person. It's a great screener. It's perinatal focus, which is really nice. If your clinic's already using it, you can roll it out there. You actually don't have to do any extra work because you're just taking this small subscale. But of course, just like any of these other screeners, you want to do some follow-up questions to figure out, like, of the perinatal anxiety umbrella, where are we falling here? And then this is a specific perinatal anxiety screener. The one thing I like to point out for folks is let's start off with the number of items. It's 31 items, depending on how many patients you see, the setting that you're in. That's a lot of items to ask for people to go through. The nice thing about it, like, so maybe it's something that you could do as like a supplemental to go after somebody has screened high on a G87 or something similar, that you could give this as a follow-up, is we've got these 4 subscales that can offer some really helpful information from a treatment planning perspective. So there is excessive worry, specific fears. There's perfectionism, control, and trauma, which can really tag on to like both the OCD, but also the PTSD piece.
I gotta
There's
get him his wet food.
social anxiety and acute anxiety and adjustment. We've got a cutoff score of 26 or higher. And again, right, it's really nice that we've got this perinatal focus, and especially for folks who are interested in doing some perinatal OCD work, right? We've got a scale that could help us to address this. Even if it is just a small one, it still is better than nothing. And the final perinatal anxiety specific subscale that we'll talk about is this postpartum specific anxiety scale, or the PSAS. This one's another one, 51 items, that is very, very extensive. This would be one that like maybe we just hold back for folks who have screened high on another shorter measure that we follow this up with. Could be very helpful for treatment planning. And here you can see that the 4 categories are really, really focused on the motherhood experience. So starting with anxieties around maternal competence and attachment, so attachment with the baby, moving into infant safety or welfare concerns, practical infant care anxieties, and then psychosocial adjustment to motherhood. So I think that this one might be a nice one to consider as you're meeting with someone and thinking about what are our big goals of treatment here, to help to delineate that for yourself, but also for your patient. Okay, and then talking about screeners for OCD. So this is, if you know anything about OCD, the Y box is going to be the gold standard there. It's not perinatal specific. It's 6 items, semi-structured interview. So you're asking a patient questions and having them give you answers about that. That's what's helping you to score this. It includes a checklist of common obsessions and compulsions. And also, we've got this cutoff score that can tell you how severe the symptoms are. It can be time consuming to administer it, right? Like 10 items doesn't sound like it's that intense, but the process itself of going through each of those items can take a while. And so this might be something that like is a secondary screener that you have if somebody has screened higher on one of those initial ones. We also have, this is an entire inventory of different series of the obsessive compulsive inventories. This is not a perinatal specific focused one either. And as you can see, as we move from left to right on the screen, those screeners get a little bit shorter. And so if you're somebody who specializes in OCD or has a desire to specialize or really work with this population, this would be another one that you could consider of, do I roll in an OCI4, which has 4 items, and then like save like a Y box or one of these longer measures for patients who screen positively on one of these shorter measures and get a little bit more in depth with what could be happening. And the final one that, again, is not a perinatal focused one is the dimensional OCD scale, or the DOCS, 20 items self-report. We follow across all of these common OCD themes. One of the really nice ones that they really aim to do to like address some of the perceived biases with the Y box or the OCI index is address bias towards more common types of obsessive compulsive symptoms. So contamination is a big one, that if somebody has contamination, it can oftentimes weigh the scoring to look a little bit more severe because there's so many questions on those other measures asking about contamination. There's also this expanded concept of severity to include distress, functional impact, and the frequency or duration of symptoms. So we're just getting a more holistic picture. We assess avoidance behaviors and also hoarding symptoms, which can fall in place with OCD as well. With OCD, we can see hoarding, it's its own disorder, but we can also see that as a compulsion itself. There's a few perinatal focused OCD screeners. There's one that I cannot remember the full name of. It's like the healthy behaviors or the parenting behaviors checklist, something like that. And then there's a perinatal OCD one, but they don't have as much great data behind them. So even though they're perinatal focused, I almost would rather use like a Y box or something similar and then ask my own follow-up clinical questions to get to the perinatal specific compulsions and obsessions versus using one of these perinatal ones that aren't so commonly used within the community. Because I think the way that we think about OCD and the perinatal period is that OCD takes real priority, that there is like a gold standard of how we would treat it, and that the perinatal gets folded on top of it, of like there's like almost the same way there's a subset of like there's contamination OCD and there's inappropriate thoughts kind of OCD. We can have these subsets. And so we think of it as like perinatal OCD as a subset within there. And so I'd rather make sure that I'm really addressing these OCD symptoms. And I know that like the perinatal could follow. Okay. And so let's move into what you're going to do in the therapy room with a patient who's got perinatal anxiety or even perinatal OCD. So the basics that we're thinking about here is that we first want to teach patients that thoughts cannot and don't have to be controlled to have somebody have a meaningful life. One of the really common threads when I'm seeing somebody who's got anxiety is that their head and their thoughts themselves feel really dangerous, or their emotions feel really dangerous. So we want to reteach that. We want to reteach that we can survive anxiety. A phrase that I use a lot in my own life, but also with other people, is like, this feeling is uncomfortable, or this thought is uncomfortable, but it's not dangerous. I can survive this. And then we also want to make sure that we're demonstrating really, really clearly that the actions to avoid or control thoughts or anxiety can be costly for folks. So we want to make that crystal clear. I tell my patients all the time that you are allowed to engage in avoidance strategies. I'm certainly not going to stop you, but I want you to be able to see the cost for what it is. I want you to make like a really open-eyed choice. What happens for a lot of people with anxiety is that the avoidance is just kind of natural. We fall into it and we're not thinking about it a lot. And so before we know it, somebody's world has gotten really, really small. And it's not because they've chosen to make it really small. It's because that anxiety has felt so unmanageable. And so a little activity for the class, like based before I get into like actually like how do we reduce like anxiety and how do we address this, is what is the common thread, right? I've got this impact on function here. What's the common thread that we can see that is happening again and again and again, no matter what the actual diagnosis is? Jen's got it. It's avoidance, right? Like that's the big common thread that we can see. And it's the biggest thing that if you're thinking from treatment, if I was to boil this down into a one sentence summary, the thing that I want to do is I want to reduce avoidance. And so that brings us, here we go. So that brings us to my pool analogy that I use all the time, but also this is like the basic goal of treatment. This is why I love anxiety treatment so much, is like really what I'm doing is I'm helping people to be less avoidant. And so all I have to think about is like, where is the avoidance? That's where we're going to drive to. That's gives me my goals right there. I don't have to do that much work. So before we start talking about like actually treating the anxiety, the first thing that you got to do is you got to build a good therapeutic relationship and build good trust. So I am always like very transparent with patients. I'm never going to ask a patient to do something I wouldn't do, right? And that includes if we're doing exposure exercises together in a session. I'm not going to ask a patient to do something that I'm afraid to do myself, right? That's not a fair request of me. And the other thing that I'm always very crystal clear about is nothing that we do in therapy is going to be against your will. I don't want somebody who comes in and they do white knuckling to get through whatever exposure exercise that we're going to do because they think that like I'm going to be upset or because this is what they should be doing. That's not going to work either, right? I want somebody to, I'm not saying we got to love it. I'm not saying we have to have a great time with it, but I want us to willingly be doing the hard work to reduce this avoidance because that's the way that we make the scary things less scary. So this brings up my pool metaphor here. So we know from looking at exposure research, like exposure, it's a behavior therapy at its core. We've had behavior therapy since the 60s, no, earlier than that, but like all of that to be said, like we have decades of research about behavior therapy. And so we know that like what we call flooding, right? Really abrupt exposures to fear is very effective and gradual exposures are very effective. Usually in therapy, I'm advocating for a gradual exposure. There is no reason that I think that I need to flood somebody with a lot of stress and make that better. I think the gradual approach gets me more treatment compliance and adherence. It has somebody more engaged in treatment long term for me. And I see longer positive effects even post treatment whenever we're doing a gradual approach. So this is where the pool analogy is very helpful. So I think about anxiety like it's a cold pool. For me, a little bit about me is I hate to get into a cold pool. I like a pool that is like maybe a little bit cooler than my body temperature, right? If it's a cold pool, not loving it. And so when I'm thinking about anxiety, it's kind of that same thing. Like I don't like to feel anxiety. I don't know anybody who likes to feel anxious. And so when I'm talking with a patient, we're got to figure out like where are we kind of tolerably uncomfortable? Are we uncomfortable enough that we can't even get into the pool area? Okay, well, then we need to stand at the fence and start just like talking and thinking about anxiety, right? Like we need to look at that pool and kind of like not engage with avoidance there. And that might be where we start. That might be where a hierarchy starts for somebody. If I'm talking to another patient, they're kind of okay, like dipping their toes in, but they don't want to have to get their legs in just yet. Well, that's where we're going to start. Let's dip the toes in, right? Let's do this in a really intentional and planned way. And we're going to make that until that doesn't feel so scary. And then we're ready for the next step. And even for something like generalized anxiety disorder, right? So a lot of those are what other disorders that we talked about have really clear avoidance techniques, right? Like, so if it's social phobia, the avoidance, right? Like I'm going to make you go to social events. Like that's what we're going to talk about. If it's PTSD and we're avoiding triggers of like the trauma response, like again, like that's exactly where my mind goes is we're going to be going to some of those trauma triggers and going to that place. And that's the exposure work that we're doing. With GAD, what I'll talk a lot about with my patients is that rumination itself can be an avoidance technique. So I feel uncomfortable, I feel stressed about my work stuff, and I feel stressed about like, oh my gosh, what are we going to do about the baby? And what are we going to do about this? And what are we going to do about that? This loop that I was talking about at the beginning, this like really cognitive brain-based kind of loop that I can get stuck in, that is avoidance of this feeling of discomfort right here. Right. So my answer there even is I want to get us out of this brain-based loop and I want to get us doing stuff even when I feel anxious about it. And so with all of these situations, right, like I'm jumping right towards what is it that we're avoiding? How do I get you doing this thing that you've been avoiding even when you feel anxiety? And this is the underlying model of why we think that exposures are very effective, right? So I'll talk to people, and I don't know if you can see my mouth the way that I'm doing this, but if you look on the left side, in general with anxiety, when somebody's coming in, the coping skills that they have are almost always doing this first part, right? So something triggers anxiety, anxiety starts to peak up here. I get to the point where this is now intolerable. I do some sort of an avoidance or compulsion behavior. Whew, I get temporary relief. and then something triggers it again, and I come back up here. So what I'm doing is I do this like, it's like a stop start. That's how I describe it to patients as well. It's like, we're doing the stop start. We never actually fully get to see that we can survive this wave. We're just like stuck moving in one spot here. And so instead, what we want to have happen, this is the purpose of all of these exposure exercises, these techniques to reduce avoidance, is I want to get to the whole cycle. I want to have this exposure to something that has triggered the anxiety to start. And then I want to be able to reach all the way to whatever its peak is. And sometimes the peak can be really high, sometimes it's a little bit lower, but I want to be able to feel that peak and feel it go away on its own, because that's what anxiety does. Another metaphor that gets used a lot, and we use this with DBT language as well, whenever people talk about riding the wave, if you've ever had any sort of exposure to DBT work, this is that same kind of model. As I expect that emotions in general are going to come and go on their own. But when it comes to an emotion like anxious distress, that's the one that people get stuck in this stop start pattern. I want them to be able to experience and ride that full wave. And when we get into the habit of being able to ride the full wave, what I'll tell people is oftentimes we find that those waves, they don't get as big as often. They don't come as often, right? And they don't disrupt our lives as often. They end up being more of like this gentle wave for the most part. And so some treatment options to think about for perinatal anxiety. To start with, mild to moderate symptoms oftentimes respond really well to psychotherapy alone as the first line treatment. So for many of these folks, we don't even have to talk about medications just yet. But for symptoms that either don't respond to psychotherapy alone, or if it's a severe presentation, that might require some pharmacological intervention. And most often that starts with SSRIs. I think something that's really critical to think about that I talk about with patients, like they might ask my opinion, or they're considering things like this, is that patients with anxiety, first and foremost, are going to have a harder time tolerating risk psychopharm discussions because of the anxiety itself. So we get stuck in a little bit of a loop there. So I'll have patients with anxiety who I'm like, oof, you actually, I think, would really benefit from an SSRI. And like the way that I'll talk about it with a patient is like, if we're operating at a baseline of, again, if I'm using a SUD scale of like a, 0 to 10 is kind of like where I like to operate. If I have somebody whose baseline is generally like they're living at a 6 or a 7, that baseline is too high. Like oftentimes that baseline means that we don't have a lot of room to grow when I'm trying to do an exposure exercise. And so getting something like an SSRI on deck from like a psychiatrist that I'm working really closely with can drop the baseline enough that we're able to tolerate doing exposure exercises and we can more effectively be involved in psychotherapy. But because again, the anxiety can make it so they cannot tolerate that risk discussion where like even doing something that could potentially possibly have this small little bit of risk there, that in and of itself oftentimes feels like an exposure for these patients. And so we can be stuck in a little bit of a loop trying to figure out how to reduce the anxious distress enough that we can make progress with our goals. But if one of the ways that we could do that is with medication, we get a little bit stuck. So if you have a patient that you think would benefit from medications, one thing I can suggest from that exposure mindset is having repeated conversations, right? There's no pressure. Again, we come back to that like core ethos of I would never force somebody to do something that I wouldn't do. And I will never force somebody to do something against their will, but that doesn't mean that I can't bring stuff up repeatedly. And so that's what I'll tell a patient is like, if I, in my clinical opinion, believe that we should be talking with our psychiatrist that we're co-treating with about upping our medications or trying a medication, I will be very transparent and say, like, just letting you know, like, I'm going to have this conversation with you again, and you can always say no to me. But I think us having the conversation is an important part of the work that we're doing on reducing your anxiety. The other thing that I think is really important to think about when it comes to medications is oftentimes patients with anxiety would love to use like a little bit of a benzo or a PRN or something to help reduce that anxious distress. I'm not saying that it's never appropriate or never useful for a patient to have access to a resource like that, but that a lot of times for like just your general patient who's got mild to moderate symptoms and is pretty functional, sometimes using a benzo, if we're overly reliant on it, can actually counteract the therapeutic work that we're doing because we've got something in here that again is kind of doing that stop start for us where somebody's not able to feel that full peak of emotions. And so it's just something to think about whenever you're talking with patients or considering what their options are, that like a benzodiazepine might be something that would be contraindicated from a therapeutic perspective of like it's reducing our ability to fully engage with the anxiety. For effective therapeutic model, there are a ton out there, right? Starting with CBT. Again, like the guiding principle that we want to think about is we're trying to reduce avoidance and increase our exposure to anxious distress so that we can teach the body and the brain that anxious distress is not dangerous. And so a lot of times you'll notice that many of these therapies, what they have in common is that we're doing a lot of doing rather than a lot of thinking. There can be a little bit of a role for cognitive restructuring. We can do a little bit of like evaluating the evidence with somebody who's got GAD, but in general, I care a lot more about the behavioral component of the CBT treatment or the exposure treatment that I'm doing. I care more that we are doing things that are values-based and are meaningful for a patient, even if anxiety happens to be carried along with us like a backpack. And so traditional CBT is very effective. Interpersonal psychotherapy is another technique that we can utilize with perinatal anxiety. There's exposure therapies like traditional behavioral exposure therapy, where like if you ever saw these videos when you were in an intro to psych class of like, oh, like I'm teaching somebody how to be in a room with a spider. And so we're looking at a picture of a spider and we move up the hierarchy. We can of course do that. But for OCD, there's also that additional component of not only are we exposing somebody to the fear trigger, we're also doing response prevention, where the response in this case is a compulsion, right? So I'm exposing somebody to the trigger and asking them not to do the thing that makes that fear go down on their own. Acceptance and commitment therapy is a therapy model that I use most frequently with my patients, or ACT is the acronym for that. ACT has a lot of good evidence. It's got kind of, in my opinion, I'm a little bit biased, but it's got the best parts of CBT in there. It's a very behavior-based intervention, but it also has some really nice components of some of the other third wave models like DBT, where we're really focused on what's functional and meaningful for a patient. So that means that like sometimes I'm not intervening on things that might be wrong if it's not functionally impacting somebody. I'm really focused on how do we get you a life that feels meaningful and how do we get you more of your life back? And that's where we're going to start. And there's also some research that suggests that mind-body interventions can be really helpful. So mindfulness-based therapies like mindfulness-based stress reduction or something similar to that, yoga, guided imagery and relaxation techniques, and then systematic desensitization, where we do exposure combined with relaxation techniques, that all of those can be really effective resources to use with these patients as well. And finally, I want to conclude with some resources, namely books. Any of these books would be good that you can do for yourself, or some of these are good books to recommend to patients as well. These, yes, have something to do with OCD, but also are relevant for perinatal anxiety disorders more broadly. And that is it for my presentation. And I think I left hopefully enough time for some good questions. Stop sharing.
Thank you so much, Lola. I'm going to stop the recording for the Q&A.